Good afternoon. We have another interesting session. And the first speaker is Dr. Gangopadhyay, speaking on synergy of Gliptin and Gliflozin, new age combination. As we know, we are flooded with such combination now, so it will be interesting to hear to Dr. Gangopadhyay.
Thank you, Chairperson ma'am. So, this is synergy of Gliptin, Gliflozin. I will try and rake up a bit of controversy, and I'll try and show you some Indian data with this combination. That is in your need of the hour. So, I will use this case as a stem, but this is just one of the barn door cases that we and you and me see day in, day out. So, 62-year-old, relatively new type 2 diabetes, not hypertensive, on metformin 1.5 grams on a statin, A1C 8, EGFR 66, and ACR is 18. So that looks like a clean-cut case of only the sugar control needs to be done. Wrong. So first I will look at the LDL cholesterol, I will look at the blood pressure, lifestyle, last I will look at the sugar. Now what am I aiming for in trying to address his problem? So one is glycemic control. That should come later on actually, but the patient has paid money to you to get his blood sugars down. So glycemic control, then CV outcome, heart failure, CKD, and non-alcoholic fatty liver disease. There are a lot of other things which might also be there, depends on case to case. So if I look at the glycemic control, so first thing is I will consider SGLT2 and DPP4 separately to begin with, and then I will tell you what is the data when we combine them. So does SGLT2 and DPP4 inhibitors work better in Asians? Now if you see, a lot of my American colleagues, when I ask them, they are very unimpressed by DPP4 inhibitors. They say, oh, it is just about 0.5, 0.6, doesn't work. We're not that keen. When I was in UK, sitagliptin had just come in, and I could see the difference. I work in Birmingham, sizable population of Asian patients, worked very well for Asians, not so well for Caucasians. I thought it must just be a fluke, but then patient after patient began to come up with very encouraging results as far as DPP4 inhibitors were concerned. So now we are unearthing the possible mechanisms. I'm not saying that we are there yet, but possible mechanisms. So this is one data. I don't have any Indian data for this. It's an Asian data, Japanese and Caucasian. So if you see, the in total GLP-1 is roughly the same, but the intact GLP-1 is less in Asians. And I'm sure this will reflect us as well. So what does that tell you? That the DPP4 probably is overactive here, and that's why you get less of GLP-1, intact GLP-1 here. So now, what about studies from India? So my talk was about Kolkata as well. So there were two studies done on relatively new diagnosis type 2 diabetes and DPP4 inhibitor levels. One was from Delhi by Dr. Anup Mishra, and this was from Kolkata by Dr. Shotinath Mukherjee. So you can see here that the control arm as compared to the control arm, the type 2 diabetes, they had more DPP4 activity and levels. So our DPP4 levels are higher. Now, why is it high? So that's the next question. Now see, this cartoon shows you, so this is the soluble or circulatory DPP4. This is the one which causes the damage. Too much of this in the circulation will eat up your GLP-1 and your blood sugar control won't be there. But this comes first as this, membrane-bound DPP4. And there is an enzyme system called KLK5 which cuts the membrane-bound DPP4 and converts it into soluble DPP4. So you see, one of the rich sources of DPP4 is actually the T lymphocytes. So this study, they tried to see what was the activity of the KLK5 enzyme in the T lymphocytes of patients from Kolkata who had relatively new type 2 diabetes as opposed to control. So if you have got more of KLK5, you will get more of soluble circulatory DPP4, bad for diabetes. So what they found was that it was more. The KLK5 activity was more. So this is just one of the reasons. And there are quite a few more, but this is one of the interesting reasons which I thought I will share with you. So in the meta-analysis, you can see clearly incretin-based therapy, not only DPP-4, but GLP-1, as compared to non-Asians, the Asians seem to have double the amount of HbA1c. That is why you and me see so much encouraging results with the DPP-4 inhibitors. So this is one slide where it shows sitagliptin, DPP-4 with metformin, high HbA1c coming down here. In this trial, they had an open-label group which had an HbA1c of 11.5%. There, they dropped the HbA1c to more than 3.5. So that is without any hypoglycemia, and that is important. Without hypoglycemia, you're dropping the HbA1c. So that's the DPP-4 Asians. Now, how about SGLT2 inhibitor and Asians? There are two studies, two big analyses. So one I'm showing here. So there they compared the efficacy and all the effects of the SGLT2 on the metabolic effects, Asians versus non-Asians. So this side is Asian and this side is non-Asian. So if you look at the HbA1c, similar, difference is here. So look at this column. It's similar. Body weight reduction, similar. Systolic blood pressure, diastolic blood pressure, all similar. If you look at the triglyceride, that's slightly better amongst Asians. The HDL increase is slightly better amongst Asians. The rest all are similar. So all in all, and going through literature, I feel we respond much better to DPP-4 inhibitors. For SGLT2 inhibitors, we respond just as well as the Western world. So the other question is, how about the adverse effects? So here, surprisingly, the genital tract infections were actually, if you see here, there's no direct comparison or p-value that I can quote, but at least numerically you can see it is better amongst Asians. Now this is now how about the CVOT? So this is a comparison amongst the meta-analysis done. So you can see here, Singh is Dr. Avdesh Kumar Singh. His data was included here. So amongst Asians versus non-Asians, so you can see he suggested that the Asians did better. This was a comparison amongst Asian and non-Asian, but was not statistically significant. In this one study, Lee et al., it suggested that it was statistically significant. So at least we don't do worse than, or we do just as well as the non-Asian counterpart. If at all, we can do slightly better. Now, the antagonistic effects of DPP-4 and SGLT2, and that needs to be, because this is what, when the combination came in, this is what struck my mind. Is it going to work? Because if I put here a DPP-4 plus SGLT2 plus metformin in black, and this is shade is just the SGLT2, and this is DPP-4. Now, what happens to the insulin? If you use the DPP-4 inhibitor, insulin level goes up. Good. If you use the SGLT2 inhibitor, insulin level goes down. What happens if you compare? SGLT2 inhibitor wins. It goes down. Because we keep saying the DPP-4 inhibitor works by increasing insulin and reducing glucagon. Now, how about the glucagon? Here, the SGLT2 inhibitor increases it, the DPP-4 inhibitor reduces it, and both combination DPP-4 inhibitor wins. So my God, I got confused. Now they are contradictory results. So will this combination work? Only the result will say. We kept telling about, football or cricket. This team on paper looks good or looks bad. Well, actually, whoever lifts the trophy is the winner. So therefore, we look at the DPP-4 plus SGLT2 meta-analysis. So here, so it's a lot of studies. So here, it's SGLT2 plus DPP-4 versus SGLT2. Clearly, the combination is better than SGLT2 alone. And again here, the combination is better than the DPP-4 alone. So no matter what effect they have on insulin and glucagon, the combination works better than either of them alone. Now, we have to look at the CVOT as well. Does this combination have any impact on CVOT? You know about these the empagliflozin trial, most of them, almost all of them had atherosclerotic cardiovascular disease, and the DECLARE-TIMI trial with dapagliflozin, majority did not have, like our patient, any atherosclerotic cardiovascular disease. Now here, again, this was done by Dr. A.K. Singh, and it came out just last year in endocrine practice. So SGLT2 plus DPP4, 3-point MACE. It crosses the midline, and the confidence interval is wide, telling you the number of patients weren't, so understandably so, wasn't that many. But SGLT2 alone seemed to be here, and it did not cross the baseline. But look at the p-value for interaction. It was not statistically significant. So we cannot say that it is worse, but we can say it is at least similar to the SGLT2. Now, if you look at the CV death or hospitalization due to heart failure, there it seemed to do better than SGLT2, the combination of SGLT2 and DPP4. No, we can't say again, because the interaction value is not statistically significant. But at least the noise is in the right direction. And for heart failure, again, it is, if they look at this point, it is at a similar level. Again, interaction was. So what I'm trying to impress upon you is that mechanistically there might be some confusion, but HbA1c lowering ability is better, and the CV benefits is maintained. CV benefits of SGLT2 is maintained when you combine both of them. So now, what about Indian studies? So do we have any Indian data on these combinations? So we now have got quite a few now. So this was the first one, I think. No, I think this was the last one, sorry. With linagliptin and dapagliflozin, you can see about roughly a bit more than 1.2% drop in HbA1c. This again, Dr. A.K. Singh was the chief investigator. MESIDA trial using metformin, sitagliptin, and dapagliflozin in patients who were inadequately controlled on metformin, HbA1c 8 to 10. Classically, this is where we use it. So patients on metformin, you're using either dapagliflozin or sitagliptin or dapagliflozin and sitagliptin, because we want to know Indian data of this combination. So here you can see there is about 1.5% drop in the HbA1c with sita and dapa. The patient is already on metformin. And if you're just using sitagliptin, there is a difference of 0.5. So again, the HbA1c lowering ability is maintained with this combination even in our Indian patients. And you've got another data similarly with DAPA and sita and metformin. Again, if you look at the baseline was lower in Dr. A.K. Singh's study, but here baseline is 9%, so you get a whopping 1.75% drop with this combination. So it works with us also, with Indians as well. Now this is another real-world data which supports what I've said so far. Now, the last 2 points, one is the CKD. So I put the patient here. So you can see here, eGFR is 66, ACR is 18. Now, in this, here is the ACR. So higher it is, worse you are. And here is the GFR, lower it is, worse you are. Now, if a patient is somewhere here, he's really bad. Very high ACR, very low GFR. If the patient is somewhere here, very good, because eGFR is good and the ACR is not raised. So where is our patient here? Our patient is somewhere here. What data? Is there any dedicated trial for this particular patient looking at CKD as the primary outcome? Answer is zilch. No, zero. There's no data directly comparing to see with renal outcome as the primary outcome. So then we have to look at other. Now, if you look at the, I've seen quite a few prescriptions where patients with diabetes are just given RAS inhibitors and ARB or ACE inhibitors, and the patients are told this will protect your kidney. So if there is no blood pressure, hypertension, if there is no albuminuria, does RAS inhibitor help? Now, if you look at the RAS inhibitor data, so this is the renal and the IDNT, irbesartan. So there, the ACR was very high. And here, the ACR wasn't that high. This is with the telmisartan and the irbesartan. But they all had microalbuminuria. It is not like our patient who doesn't have anything. Steno 2 trial, again, it had microalbuminuria. So that's why I'm stressing the point. There is no direct evidence for this. So the KDOQ had said, patients who are normotensive and there is no albuminuria, available data suggests that there is no evidence, or it's not, they've just said, are not beneficial for patients with neither albuminuria nor elevated blood pressure. So then what do we have? So we have to look at other data and see, extrapolate their findings to this. So here at the bottom, you see, all the other are spread around here. So you can see DAPA CKD here, EMPA kidney here, Figaro, all are spread out over here. So the data we have closely mimicking our patient is the SGLT2 inhibitor. So this is EMPA-REG, CANVAS, and DAPA declared TIMI, because this had the highest EGFR amongst these three. And you can see here, 70% of patients in the DAPA CKD had urine ACR less than 30. 70% of several thousand patients, of more than 16,000 patients. So you can see the big number of patients who had ACR of less than 30, and they were shown not to have progression of their CKD, or it retarded the progression of CKD. Now the last point is NASH. You know that the recent AD has mandated that we do FIB-4 score for each and every patient with diabetes, and I'm beginning to do it now. Why? Because even in patients who have normal SGOT and SGPT, you get a very high risk of having non-alcoholic steatohepatitis. So you must do FIB-4 score for each and every patient with diabetes. So therefore, we have to continuously look at agents which does not have any detrimental effect on the liver, if at all, have some beneficial effect on the liver. So with the DPP-4 inhibitors, there is evidence that it does show reduction of the SGOT and SGPT. A maximum data you will find is with sitagliptin. However, there is no data with DPP-4 inhibitors that it reduces the progression of fibrosis, nor does it improve the fibrosis. And there is very little biopsy data. We have got radiological data, we have got biochemical data, which suggests, if at all, it is in the positive direction. But there's no data to suggest that it retards the progression or reverses. But we have to choose agents which at least doesn't do any harm and possibly some benefit. So if you see amongst the DPP-4 inhibitors, you have got data with many of them, but I think sitagliptin here takes the winner cup because it has got maximum data in patients with liver disease, even in trial in patients with chronic hepatitis C infection. Of course, the combination, the GTI, I still don't know the answer why the genital tract infection is less. There are a lot of theories put around that the fungus has got DPP-4, which is inhibited by the DPP-4, so therefore you get less. But we don't know the exact reason why the GTI is less when you combine with SGLT2. But you should not extrapolate this to UTI. This does not mean that this combination reduces UTI as well. There's no data to suggest that it reduces UTI. So I think the currently existing combination in India, if you put the SGLT2 here, and if you put the DPP-4 here, you get these sort of combinations. So SITA and DAPA, VILDA, DAPA, and everything else. But these three lack CVOT, or their CVOT is not positive. And most of our patients are prone to have CV problems. Vildagliptin has got the added problem of we should not be prescribing in patients who have got deranged LFTs. So we are left with DAPA-SITA and LINA-DAPA as the combinations in my practice, which we can confidently tell the patients it will not do any harm. Do no harm is the dictum. Will not do any harm. If at all, it will do the benefit, and it retains the benefit which the SGLT2 inhibitor offers. So I think coming back to the case, here clearly the SGLT2 DPP-4 combination will click most of this. If this was 15 years ago, we will have to give sulfonylurea. Mind you, I use sulfonylurea quite a bit. But now we can have this combination, which without causing hypoglycemia might help us achieve all these targets. So thank you very much. I've got 15 seconds left.
Thank you, sir. That was very clear message. Any questions?
Sir, we see a lot of post-transplant patients nowadays, post-liver transplant, post-kidney transplant. Can we use these drugs?
Okay. So I think in the post, I cannot say about post-liver transplants. Post-kidney transplant, you have got evidence with DPP-4 inhibitors, linagliptin in particular. You are now getting evidence with SGLT2 inhibitors as well. So yes, for post-renal, you have got. Post-liver, I'm not sure.
Sir, in a drug-naive type 2 diabetic patient coming for the first time, not having any osmotic symptoms, if we straight away, if the HbA1c is more than 9 and we straight away give a combination of DPP-4, SGLT2 and metformin instead of starting a insulin, will the patient tolerate it, and how is your experience for this?
Very broad question. I'll need 20 minutes to answer that. But to shorten it, you have to be careful when you say HbA1c more than 9. You know, very high HbA1c, skinny patient has a lot of weight, insulinopenic. That chap will need insulin at least for the first 2 to 4 weeks. No question about that. If you have already said that no osmotic symptom, if there are osmotic symptoms, the SGLT2 inhibitor might make it worse. So I'll be a bit careful when you cross 9 or 10% with this combination to begin with. I'm comfortable if it is below 10 or more comfortable if it is below 9.
Thank you.
Any other question? So, thank you, sir.
Okay.